Um, we would like for you to be sure to let us know that you're here. As you can see here on the slide how to verify your attendance. You text to that number there with the code 22258 so that we can track attendance and participation. And we really appreciate you being here and being a part of this dialogue. So today's topic is one that, not surprisingly, arises from our ethics consultation work. And this is a topic that I think many of us struggle with, trying to think about the ethical boundaries that surround patient requests to leave against medical advice. And not that we're promising we have all the answers today, but we really hope to engage you in some dialogue about how we might approach this issue. And we've got a great panel to do that. So I'm going to ask our panel to introduce themselves first, and then I'm going to move into the case and start with Jackie.
Good afternoon. My name is Jackie Bradstock. I'm a lead clinical nurse on the CVPCU Diet West cardiac surgery.
That's fast. Jeff Natterman, I'm a risk manager for health system. I'm also a respiratory therapist. So I spent many years at the bedside and then went into law, and so I am the legal advisor for the day.
Simone Thompson, I'm a senior clinical social worker in pediatrics and also the child protection team coordinator for the hospital.
And in just a moment, we'll have Dr. Hertzke joining us, who will introduce herself when she arrives. So our topic for today is patient requests to leave against medical advice, the ethical boundaries and clinical realities. And so we're going to initiate this conversation using a case to illustrate some of the issues. This is a case that is a composite case that reflects some of our experience. So we're going to use it as a jumping off point. You all should have a handout. If you don't, it's right there on the front table. This is a case involving Marcia Edwards, who's a 58-year-old woman with a long-standing history of diabetes, chronic renal insufficiency, COPD, and a history of panic disorder and alcohol dependence. She's been hospitalized 5 times in the last 12 months for a variety of problems, including hyperosmolar hypoglycemia, COPD exacerbation, alcohol withdrawal, and neurosepsis. During her recent hospitalization, she frequently refuses treatments, which extend her hospital course. And she's left against medical advice on a couple of occasions. In the past, she's been evaluated by a psychiatrist who determined that she had the capacity to make the decision to leave the hospital, that they did not think that she had an affective disorder or a psychotic disorder, but did judge that her alcohol dependence was an important impediment to making sound decisions. During this admission for pneumonia, she's been verbally abusive to nursing staff. She's refused basic nursing care and intermittently accepted bypass and nebulizer treatments for her respiratory distress. She has hypoxia and is on nasal cannula oxygen. After being in the emergency room for 24 hours, she is now on day 2 of her hospitalization. She's still on IV antibiotics, and she insists on leaving the hospital, saying that she wants to go home to feed her cats. The clinical team thinks her condition is tenuous, and she continues to require 4 liters of oxygen, and her respiratory, they're really worried that her respiratory status could get worse. They recommend continued hospitalization to make sure that she gets her full course of treatment. The clinical team has requested assistance in deciding whether it's ethical to permit the patient to sign out AMA or against medical advice. So you kind of get the sense of the layers of ethical concerns that this case illustrates. So before we begin, I'm going to welcome Dr. Hersky
Yes.
and ask her to just
Perfect.
introduce herself really quickly, and then we'll turn to our panel for some reflections. Want to introduce yourself?
Sure, I'm Carrie Hersky. I am a pediatrician and an internal medicine physician, and I am one of the Associate Chief Medical Officers here at Johns Hopkins.
Wonderful, thank you. So to begin our conversation, we're going to ask each of our panelists to just reflect on this case. What are some of the ethical issues that it raises? What are some of the realities in our clinical practice that we are confronted with when cases like this come up? So we're going to start with Jackie.
That's what I get for sitting on the end, I guess. I think it can raise a lot of questions initially, reviewing this scenario. I ask, does she have capacity at this time? How hypoxic is she if she's been refusing her BiPAP? Is she delirious? Is she septic from refusing her IV antibiotics and having the pneumonia? Because obviously our goal is to take the best care of our patients that we can, and we want great outcomes. Also, saying that she wants to go to feed her cats, does she have cats? And is that really the reason that she wants to leave, or is there a different reason also? And I think here at Hopkins, we have great resources like community health workers, social workers, and even our clinical customer service coordinators that can help at the bedside dig in to see what those reasons are and maybe find resources that if it is just the cats, can we find someone to go to her house and feed them for her? And then if it's not, is it the alcohol dependence that she has left for previously, and addressing that with her and considering treatment for that. So, whether it's medication or whether it's giving her alcohol, we have multiple options here at Hopkins, and we definitely just need to have the conversation. And I think as a bedside nurse and a charge nurse, part of our job is helping to facilitate those conversations with between the patients and providers, and help facilitating the understanding of what's going on, the true depth of the situation, how sick she really is. So I think having her evaluated for capacity, depending the scenario, is important, and we can contact psychiatry for that. And we've used our ethics committee when things have gotten a little touchy with these kind of situations. But I think it's fair to attempt a conversation with the patient to determine if we just simply need to change our plan of care.
So the things I think about in these situations are, this is very common, right? So it's common that we as a medical team feel very strongly that certain things are needed for our patients, and it's common where patients may not feel strongly in the same ways that we do about what things are needed to help them get better. I think it's very common that patients express a desire to do things like pay rent, care for pets, see family members, and while they're in the hospital, and we have an environment that makes it really impossible for people to go leave the hospital and come back for, I think, very good reasons. And in these cases, it is really challenging when we think that patients are making decisions that are not in their best interest. We have moved very much away from paternalism in medicine because we have been so far on one side where we thought we knew best. But it really can put us in these binds where we feel conflicted about trying to honor the patient's wishes when those wishes we worry may create harm, like in this case where the outcome could actually be pretty unpleasant or unfortunate for the patient. I think you win patients when we feel uncertain about patients' capacity, or that the capacity is borderline. It makes it even more complicated trying to navigate these issues.
So we get this call a lot, and attorneys on call. I've got some of my colleagues in the audience at the moment, and they know that the first question we ask when a nurse or a physician calls up with a patient that wants to leave against medical advice, and they're very concerned about that patient, the first question is, do they have the ability to understand the consequences of their decisions? And that's because everybody here knows that it's a fundamental right for a patient to make their own healthcare decisions. I mean, that's the North Star, really, is if you're a patient laying in bed in a hospital and you decide you don't want something done, if you've got the capacity to make those decisions and understand those consequences, then you have the absolute right to not have that done and to make those decisions. This case scenario is about as bad as it gets in some ways, and that when we posited it that way for a reason, because he's come up all the time. And so from a legal point of view, the fundamental question, first and foremost, not only does the patient have capacity, but who's assessing that capacity? And that becomes a very important legal principle, because in Maryland at least, only an attending physician, the attending physician, who's currently taking care of the patient, primarily responsible for the care and treatment, can assess capacity, and a second licensed physician. It can be a psychiatrist. It doesn't have to be a psychiatrist. And so you often find that when somebody says they don't have capacity, it's a non-physician or a non-licensed physician, and that's simply not good enough for determining legal capacity. So once we get that sorted out, gosh, I could talk the whole time about this, so I'm going to try to keep it short. Working with the team, if a patient has been determined to have capacity and they want to walk out the front door, even though they know that bad things are going to happen to them, you have to let them go. I mean, there's a legal principle that says they have the right to walk out the door knowing what the consequences are. Having said that, we often try to find ways to encourage the patient to stay that has capacity. And so, starting with warm and fuzzy and all the way with, I don't want to say cold and prickly, but being as creative as you can to get them to stay. We will pull out every stop on the organ that we possibly can to get them to stay. But at the end of the day, if they want to walk out that door into a cab, the best thing that we can do is make sure that the discharge plan is as safe as possible, getting them from point A to point B, and then creating some sort of outpatient treatment plan for them that would be safe. And I'll stop there.
I do think it's important, I agree with you that we want to try to be really thoughtful and think about ways to keep this patient in the hospital. I do find that we have a number of patients with sort of lured IV narcotics or other treatments that I think are not in their best interest over us, and I would say that in those cases I actually don't think that we should be giving patients things that are harmful in order for them to stay.
The dynamic of this changes when the patient is receiving pediatric care. So if it is somebody that is under the age of 18, typically speaking, they are not making their own decisions about discharge. So the question would be, what if a parent is stating an intent to leave with their child against medical advice? And so the question of capacity on the part of the decision maker is still present, but it's capacity of the decision-making parent or legal guardian. But the rest of the principles still hold true. They have the right to make decisions that may be different from what the medical team would recommend. The both benefit and difficulty is figuring out where that right ends and the child's right to safety begins. And having even different medical providers from the same team weigh in on how risky would it be for this child to leave the hospital can be an interesting conversation. What has to be determined to the degree possible is, does this represent an acute risk of serious harm to the child? And understanding the greater contextual issues for why the parent wants to leave, what their concerns are, and how the communication with the team has proceeded to this point is critical in terms of determining how to go forward.
So when we think about what Simona's just suggested, part of our struggle is first of all, how do we assess capacity? And then what is a sufficient effort on our part to be able to try to create the conditions where the person can get the best care that they actually need. So I want to turn to Jackie here for a second. Part of the case here was the patient refusing basic nursing care. And what we know is that when patients don't get the kind of treatment that they need, it does impact their outcomes. So what kinds of issues does that bring up as a frontline provider of offering therapies that the patient refuses, and then it ultimately says, no thank you?
Well, to be honest, it's not usually a no thank you. And, part of the struggle at the bedside is how mentally exhausting sometimes these patients and scenarios can be, and a stigma is created. And in handoff report, you're going to hear from the previous nurse that, they refuse their back, they refuse to walk, they're refusing their meds. Practically, why even go in there? And it kind of challenges us as a nurse to really put our pride aside, go in the room, offer the best care that you can, because you might be the nurse that convinces that patient to accept your care. And of course, she or whomever has the right to say no, and we can respect that. And just offer supportive care. But I think a lot of it is, how do we change our care and our plan of care for these patients and offer more shared decision making rather than going in with the plan and expecting them to go along with it. So if she needs to go off the floor to smoke, which we personally don't want them to, but if that's going to work, we give them a time frame. You can go off for 30 minutes at this time, but let's compromise, and you be back for your antibiotics at 2 o'clock, or whatever that is. So it really requires us to be flexible and open-minded and come up with the shared decision making. I think makes a big difference.
I think from a physician standpoint, similarly, I think it's sometimes it can be really rigid in what we ask patients to do, and so if there are ways that we can space vitals or skip vitals overnight or loosen their dietary restrictions, that's a big area of contention, or really minimize the times of their NPO, things like that I think are very helpful. I have seen providers who have gotten a little bit stuck and feel compelled to do things that I think actually are not in the patient's best interest in an attempt to keep patients here, especially when they're sick like this. And I think that is where personally and I think ethically it's reasonable to draw the line even if the outcome is not going to be what you want. So again, the IV narcotics, or for example, leaving the floor when they're on the step-down unit or in the ICU. Those are things that really we would argue if those patients need to be in that high level of care, having them leave the floor is really not medically appropriate. And if they're going to make those choices, then that is a choice that is going to result in them deciding that they're leaving AMA. And I think one of the other things to think about is if that happens, trying to still be supportive. And so, if you do this, then we're going to say that you're not ready to receive more of our care, but we'd love for you to come back to the emergency room because we'd love to take care of you again. And trying to reduce the stigma as much as possible, I think is helpful, but in a moment can be really, really hard.
Just to add on to that, I think we can be successful in planning the discharge rather than having them sign the paper and then they're gone. We can still go through their discharge information with them as long as they'll tolerate. And the aftercare clinic, I think, has been a great resource for some of us and our patients. So if they don't want to go back into the emergency department and wait for too long, and if they're not too sick, then setting up an appointment, sometimes they'll stick to that.
Thanks. Yeah, I think, Carrie and I have worked together for years now with these really difficult situations, and I think we would probably agree too that one of the stickiest parts from a legal risk point of view is inconsistency between team members. When you come, God bless you. You're welcome. When you come up with a plan, it has to be globally accepted by the entire team to be successful. Because what really hamstrings us when we're trying to do a behavioral management plan with, and we don't call them contracts anymore. We're trying to get away from the concept of a contract because frankly, patients don't agree with it most of the time anyhow. They're not going to sign a contract. But we are setting up behavioral management plans. I think from a legal risk point of view, when we get brought into a situation, first of all, it would be really super nice to not be brought in when chaos is breaking loose. You know, and we piloted it, and I don't know if anybody here is from the NICU, the Medical Intensive Care Unit, but we piloted over a year ago this concept of a behavioral liaison team. It's the BLT. I did not name it that. But it was this effort to be proactive when you sense something was about to not go well with a family or a patient. And it was a multidisciplinary work group of multi-stakeholders to try to figure out what the best plan would be to prevent an escalation. And I think we've had some really good successes with that. I think we've had some hiccups, but we've definitely had some successes. So from our point of view, the attorneys that take call or the risk managers that take the call are going to work closely with the team, and facts become critically important. Who are the authorized decision makers in the event the patient loses capacity? Who's a family member that can help maybe persuade the patient to stay? What resources does the patient have if they end up going out the front door? Are they homeless? Are they mobile? There's a whole bunch of checklisty type things that we need to think about when we start talking about this concept of discharging somebody against medical advice.
Part of what I've been impressed by on a number of occasions have been two things. One, to follow up on what Jeff said, when there are differences within the team about, or whether it's the present team or a past team and the current team, but the patient is the same. When there are differences in opinion or differences of practice in regards to treatment of the patient, becoming increasingly adamant that something is absolutely necessary becomes problematic. So the parent or the patient is saying that they're ready to go home, that they've gone home in a similar circumstance before, and the provider says, no, it's absolutely unsafe. You can't go home receiving this level of oxygen or this, frequency of whatever, different and certain medical intervention here. And the parent's like, well, but no, we were just discharged in October with exactly the same, and you look back at it, and in fact, the patient looks pretty much exactly the same as the last time where they went home without conflict. And so when presented with that information, sometimes rather than being sort of allowing themselves to step back and be objective, it's as if you're watching someone who is feeling cornered professionally. And rather than saying, thank you, that's important information for me to consider. Let's talk about that. How did that work for you before? In fact, did you have to be readmitted because the patient was presenting with X, Y, and Z? Or is it part of a long-standing, underlying condition? But let's work together to understand this. Instead, what I've seen some providers do is take the questioning personally. How dare you question my professional judgment? And instead, what I will do is ratchet up the stakes involved. Oh, if you're going to threaten to leave, then we'll just have to call security. You're going to have to stay. Oh, so you're going to threaten to leave? Let me get social work involved so they can call Child Protective Services. Let me just say that never helps in communication. Having 10 or 15 security officers outside the door, one of whom has on their own already called Child Protective Services before I even, as the social worker available that day, have arrived to talk to the family. There is no amount of backpedaling that will improve that situation. probably ever. And so that's one point. The other thing that I've noticed is, and it sort of goes along with the same thing, the issue of stigma has been brought up. There's also sometimes very, very punitive language that's used, impressively so. And I think it's easier for me to see because I'm often walking in. I've not been part of an ongoing conversation. But I remember a dialogue about a patient that was leaving earlier than recommended. And the team said, well, fine, then we're not going to give you any of the supplies you need for going home. And it was things like bandages for a wound. And I was completely dumbstruck that it was even something that somebody would think of to say, because it's so clearly not only unethical, but completely against the provider's medical best interests as well. So you send the person out without the necessary supplies, they get septic, they come back to the hospital. So anyway, I think that being able, though it is extraordinarily difficult and sometimes takes another provider to say, hey, yo, I think maybe you need to take a breather for a second, however that medically is communicated. It's incredibly important to have colleagues and to be able within yourself to remember, oh, right, somebody disagreeing with me is not about me. It is about what they want for themselves and for their family and what their needs are. And the best thing I can do is try and understand where they're coming from.
So Simone brings up a really interesting point that I think for clinicians struggle a lot with. You know, our commitment is to the welfare of our patients. That's why we're here. And it is very difficult when you're trying to help someone who continually refuses your offer. Because it is often, you know, comes out of a place of wanting to actually do good and to reduce the harm. And when you see the harm in front of you as a clinician, it begins to feel like, how can I see myself as a good doctor, nurse, respiratory therapist if I'm not actually benefiting this person? So I think there's probably some explanations for where those responses come from, because it comes out of often this sense of feeling as if their efforts to benefit the person are just being, you know, sort of thwarted at every move. It doesn't justify the behavior, but I think there's an explanation for where that sense of frustration comes from. And yet, we're here to try to serve very complex patient situations and social situations that are not easily fixable. And I think that leads us to this sense of helplessness, that I can't fix this problem. I can't convince this person to see that our efforts are really meant to benefit you, and where that leaves us as clinicians in that sense of sort of despair and distress that we experience. So I'm going to open it up to questions, comments, and we'd invite you as you share a comment or a question to say your name and to ask your question either specifically or generally to panelists. Want to stand up?
David Meyer, Master's in Bioethics student. I'm curious about a situation where you have a pregnant woman in the late stages of pregnancy where the fetus is viable, and two settings: the patient either lacks capacity for decision making and a C-section is recommended, or the situation where they have capacity and refuse a C-section. How does one proceed? And I wonder if the fetus, the viable fetus, has any rights.
I feel you're looking at me.
He said right. So
Right.
all in
Anyone can answer.
Wow. Gosh, you started off with a really hard one.
I can do the CPS part, that's their board.
Yeah, thanks. So actually, I got a call like that a couple of years ago. And of course, anything we say here, of course, for internal education isn't a HIPAA violation, but I will change some facts. So maternal rights over fetal rights. That's the bottom line. So the mom gets to make the decisions on behalf of her and her baby. That's the principle that we follow when we get those calls. And again, we always try to do what's in the mother's best interest, and we want to do what's in the fetus's best interest, but the mother is the one that's making those decisions. Now, having said that, facts are stubborn things, right? John Adams, I didn't make that up. But when we get these really wild calls about what's going on with a late stage pregnant mom, and we had one recently where mom who was a substance, I don't want to say abuser, what's it? Abuser, thank you. Thank you all, by the way. So mom was high as a kite in the labor deck, late term, and this was like a 1 o'clock in the morning phone call. I'll never forget this. And first of all, mom was violent and was throwing Kelly trays and materials, and when they called me, I could hear it on the phone in the background going on. Is that me? It's a message somewhere there. Okay, not that I'm superstitious. But the first thing that came through my mind is, my God, why are you calling an attorney at 1 o'clock in the morning with a mom that's going ballistic on the labor deck? And the question was, can we sedate her? Because she's about to harm herself or kill somebody else or the baby. And my take in that emergency situation is, do what you got to do to protect her, the milieu, and the baby. I mean, from a legal point of view, you do what you got to do to protect the milieu, the patient, the fetus, the staff. I mean, I'm sorry you had to call the attorney. I wish we had a protocol for that, but it was just one of those one-outs where they weren't quite sure what to do, and they didn't want to get in trouble. That's what floored me more than anything else. You're worried about, like, protecting, I don't know why we're talking, just sedate her. And I'm a lawyer. I'm not allowed to give orders for sedation, right? And I get that, we get that all the time. Can I do this procedure? I'm like, is it clinically indicated? You know. So to your point, it's a long way of saying maternal rights over fetal rights. Mom makes the decision. But we do everything we can to try to protect mom and fetus.
Just on a very brief thing, this is a little different and it's not typically the question, but I do get questions about maternal over fetal rights and whether Child Protective Services needs to get involved. State law does not consider a fetus to be a child, as is covered under the Child Protective Services laws and regulations. So birth on is once the regulations kick in.
I'm Judith Vick, internal medicine intern. And I actually want to respond to your question. I don't have a question of my own. Just that I had a patient exactly like that in medical school on my OB-GYN clerkship. And actually it wasn't my patient. I was told as a medical student, stay away from this patient. This is just a legal mess. You don't want to get involved. But I heard a lot about it. They called legal. It was not at this hospital. They called legal in the middle of the night. She wasn't violent or using drugs or anything like that. But then one resident went in and asked her why she was refusing a C-section. And the reason was she thought that if she had a C-section, she had to be under general anesthesia and she wouldn't be present for the baby's birth. And once that it was explained to her that it didn't have to be the case, if it wasn't an emergent C-section, she agreed to the C-section. And I've taken that story with me because we always jump to like legal and what are we allowed to do and everything like that. And sometimes communicating in that way can work for everyone.
Does this work? One of the things that I was thinking when you were talking about how everybody gets triggered when people refuse or / decline something is that and I guess in our own setting, I work in OB in the nursery, is that I feel like sometimes we've lost touch with what it means to be empathetic. And what the real, and I stumbled upon this thing on LinkedIn recently about, it was this woman talking about empathy for like an hour, and I listened to the whole thing. And I thought, gosh, I thought I knew what empathy was. And it's really hard because when people come for our care, you wonder what motivated this lady to come in and what happened to make her disconnect and not want to be here anymore. And what an empathetic position, which apparently being empathetic is a lot harder than we think it is. I think, and it's not sympathy either, but I think we're also triggered, and I guess by people doing things that they remind us of our family members or our own values. And I've been sort of saying we need to get back to empathy. And I would question what brought this woman in and what happens when people don't want us anymore and we get rejected. Like, how do we stay connected to sort of keep the needle threaded rather than get reactive? And we live in a litigious society, so I still call it legal, by the way, Jeff. But that people do worry, well, oh, what if this happens, will I lose my license? Or does somebody have the right to do something really stupid? That remembered their brother who did that once, or their drunk uncle, and everybody kind of becomes sort of a hot mess. And what empathy have been made it different. It kind of strengthens your center on how you approach the patient. So
I think that there's a lot to be said for that. I think it is, I see sometimes people get stuck in this sort of, and the OB case is probably a good example of like, this is the recommendation and like, everyone can die if you don't do it. And it's not that those aren't true, but just sort of backing out for a minute, I think there is a lot of room to take everyone on the team to take a deep breath. And we are people, which is good. We bring our own sort of, I know, but like we sometimes expect that we are not people, right? And I think pretending like you don't have your own baggage and your own feelings and your own approaches is really not likely to be successful, because you do. To your point, and empathy is actually really hard. Mr. Rogers, like there's this whole thing about Mr. Rogers, right? You listen to like all the podcasts are coming out about it, right? It's like super depressing. So I'm like, how could I ever be that cool? Because that's what they sort of talk about is his ability to sort of teach empathy and have empathy for people that were different. And we are asked to do this often. I think it's really challenging. I think it's important to think about the having empathy, but I also think it's really as important to not. I think we want to make sure that we even contribute to this situation, because sometimes we do in ways like the OB case, right, where we haven't just explained or we haven't taken a moment back to understand why. There are many times, though, in which you have people sort of like literally crying about the situation, and then I worry, I'm not convinced it helps us when we are unable to separate and we take this as a personal failure, because I think that's where we get to making decisions that are no longer in the best interest of the patient. Or we just can't have conversations that are most helpful, because people ultimately at the end of the day, if they have capacity, all have different value. We all in this room have different values and different things that are important, and we would make different decisions in different situations, and it's hard to know what any of us would do in a given situation in a healthcare setting unless we're in it. There's lots of studies showing that. And so I think it's important to have empathy, but also not to have so much empathy that you can't separate and realize it's not about you. This is sometimes about you if you need to think about how you are you being too rigid, have you communicated, but a lot of times this isn't about us as providers. And I think it's important to sort of be able to separate ourselves so that we aren't personally offended about these decisions.
Yes. I'm Vivian Altieri de Jesus. I'm a Master of Bioethics, and I have a question regarding, after ensuring that the patient has capacity, how does it place to have judgment towards the patient reasoning? And I talk about the experience because following on the pregnancy trend, we have a pregnant woman that she decided to go MMA. She didn't want to remain in the hospital, although she had the risk of losing her pregnancy. But the reason, she was determined to have capacity. But the question afterward was the reason that she gave. So her reason was because due to religious belief. Whereas, for example, some of the discussion that got was, well, if she said that she will be taking care of her children, it will be more reasonable. And something that actually got with me throughout the master degrees and everything. And I was wondering if there is a step or if that shouldn't be done. Like, we just determine that the patient has capacity and we just accept that and let them go MMA.
I mean, I think understanding the reason why people are making decisions is helpful because you might be able to intervene on those reasons occasionally, right? But in the end, it doesn't really matter if a patient has capacity and wants to leave. It could be because they want to put purple socks on and purple socks are only at their house and they don't want you to deliver purple socks, and it's somewhat irrelevant, actually, to be honest. For me, it can feel more disappointing, I think, in some ways, but that's sort of where I need to step back and say, like, that's not my decision, right? Have I mitigated and tried to have empathy and tried to do everything I can? And at the end of the day, we all have different values, and this isn't about my values, actually. It can't be.
How many here have a will? Anybody? Awesome. Actually, I thought it was going to be like one person who agrees on that. I bring that up because when we talk about capacity, that is a really difficult subject. And there are different legal types of capacity. So to make a will isn't the same as making medical decisions. Testamentary capacity just means you have to be able to write your will out, and you can be delusional and still write a will. It's been upheld in court. Medical decision making is a much higher caliber of capacity. And there's really not much in the way of guidance, at least in the state of Maryland, for how providers are supposed to do that. And we struggle mightily with providers on how to assess capacity. In fact, a collective effort just produced the very first capacity policy for the hospital here and trying to get guidance for that. The best that the state has is whether or not the patient is capable of understanding the consequences of their decisions, the risks, benefits, and alternatives. But the state really leaves it to the provider's judgment based on the presentation of the patient to figure out whether they can understand the consequences of their medical decision making. And so that can be kind of problematic from team to team, provider to provider. That's why we love legal calls. So.
What about in a state like where I often think sometimes it seems like a death wish? And so does it come down, is this assisted suicide?
Oh gosh, that's a great question.
And would it be different in Oregon? So what do you do when it seems like the patient just is hell-bent that they really just are done?
Well, so we just had a case like that. Oh,
How would we do that?
We just had a case very similar, well, not very similar, but close enough, where, somebody that keeps making really horrible decisions, and you start to ask yourself, what is the deeper root here about why you're making those decisions? I mean, that also is, I think, a clinical psychiatric judgment that needs to be made by professionals that can make those determinations. I know Carrie and I recently had a case where, it was a couple of weeks ago, where it came up, like, is there passive death wish here? And that was just a confab between legal and the team to ask that question and to see if we couldn't get a psychiatric consult. It's tricky.
Yes.
Hi, I am a social worker in pediatric oncology, and I had an 18-year-old patient sign himself out AMA after recovering from surgery, and he was on a different floor. And so he apparently had a very stressful, horrible time signing himself out. And I just wondered, nobody called any of us up on oncology that have worked with him for years. And I just wondered if that was something missed, or is it our standard practice that the people that a patient is with in the moment are the voices that matter when dealing with AMA? Or should they have brought more people in?
So I actually remember that case because it was on the weekend and I happened to be working. And God bless nursing. I mean, without the actual God bless component, but you know what I mean. Like, thank you to bedside nurses. Because nursing, I believe in that instance, felt that they had been pushing back against the medical team, which was not his ordinary medical team, right? So he's an ongoing oncological patient who is known to that team, known to his social worker. They know his personality quirks. They know that he usually, I'm making things up, but complains adamantly before agreeing, or agrees and then complains adamantly. I mean, you know, but every patient over time, you get to know who they are personally and how that impacts their communication with the medical team. That was lost for him, which actually makes him more like many of our other patients, in that we don't have history. Nursing, I don't know. It was the nurse that day who said, I was trying to work with surgery, with the medical team all day to figure out how we could make this less confrontational. But what made it more complicated was it being the weekend. So not only is he not on the team that knows him best, that he is used to communicating with and knows how to share his concerns and frustrations. He's like, ordinarily I would do X, Y, and Z, and people would listen to me. Why isn't that happening now? They want my mom here. Why? I'm 18. I can make my own choices. And that actually just made him even more upset and less able to engage. But what was clear was that the less experienced physician, and whether it was because he's less experienced, whether it was his own personality, I don't know, and I didn't get a chance to engage with him, but the patient himself felt that it had become personal. And he said he started to threaten me, not physically, but this was the one where, fine, we just won't send you home with the supplies you need. And that was the point at which nursing called me. Now, had it been a non-weekend, I think if they had called the unit social worker would have reached out to the staff that knows him more, and that might have helped with circumventing some of this. But it sort of goes back in a sense to the example that I gave earlier, both the benefit and consequences of patients who have an ongoing relationship with the hospital or with a particular outpatient provider, and then engage with someone else and perceive that interaction to be substantially different, whether it's around the recommendations, whether it's around the style of communication. And that by itself leads to a disconnect that I think increases the risk of the patient wanting to leave, and then wanting to leave AMA when the provider, like I said, ratchets it up to being more and more strident about why it's not okay. And I think the other thing about it, and this goes back to empathy, is the patient was wanting to leave for his uncle's funeral. And this was a person who had been incredibly critical in his life. And he's like sobbing as he's saying, well, so now we've effed around with this all day. And then he's like, oh, I mean, I'm sorry, I'm using profanity. I don't want you to think that I'm really angry, except that I am. But he was clearly conscious of his presentation and what he was about. It's like, but we've messed around with this so long that now I've missed this event. But to hell if I'm staying now, because I have no relationship with this person. I don't trust him and I don't trust the team. I'm done. I'm done. And it was hard for me at that point. All I could do was actually see what he was saying and ask nursing, how dangerous is it actually for him?
So I wonder if, thinking about these cases and the themes that come up, what are some of the red flags? You know, we've seen these cases repeatedly. Are there some factors that are, you know, this issue of lack of continuity or disagreement among, you know, clinical teams? Are there some red flags that would be useful for people to just be aware of as these cases come up?
I mean, I'd say the lack of continuity is a huge difference. You know, I can work with a provider one day that has a certain opinion and a different one, and it's so challenging to then have effective communication with that patient. and continue a plan. But I think,
Patient characteristics, are there team characteristics?
yeah, I mean, well, as a team, definitely the lack of continuity of care, and then as a patient, red flags could be just them getting like easily frustrated, them refusing care all of a sudden, and so I think the most important thing is the communication, the empathy is the ongoing challenge, and trying to really stick through that and asking the why question.
I think patients with substance use, especially if it's active, have more risk because we can't always provide, or sometimes we don't always provide replacement for that substance. And so like in this case, it's harder to provide a replacement for alcohol if you're not actually withdrawing, unlike some of our other substances like tobacco or opioids, that we don't do a very good job of providing opioid replacement therapy in the hospital nationally. So that's a red flag. Obviously, like anything else in medicine, right? So if you have a seizure once, that puts you at risk to have a seizure again. So if you've left AMA once, that puts you at risk to leave AMA again. And so those are red flags that patients may be at more risk to leave AMA, or if you've eloped, which is that you've left and not told us, that puts you at risk, likely to do that again. The other thing I think about is personality vulnerabilities, and so patients that have active psychiatric disorders may be more likely to leave AMA, not necessarily, and I think it is important. There's a really beautiful study that was done by Sophie Landskron and her colleagues here about the language that we write in the charts and how that really sadly, but not surprisingly, colors the way we approach patients. And so I think while it's important to think about red flags, because it may help you to go in sort of differently and try to partner very early on. We can say that we should partner with everyone because we should, but automatically you may sort of adjust your approaches early on. I'm hopeful that would be everyone's goal instead of to label folks, which is, it can be tempting because we all have biases, many of which are not conscious actually.
Hi, my name is Marlene van Schaik. I'm a visiting scholar from Amsterdam Medical Center. And I was wondering, from a care ethics perspective, you would look at the responsibilities. And I think a lot of the responsibilities from the healthcare professionals were already implicitly mentioned, such as, for instance, do no harm, or to try and provide good care. But there are also responsibilities on the side of the patient, such as being responsive to care. I was thinking that is a different approach than looking at capacity. Would it be more helpful to look at responsibilities in this case? What do you think?
Absolutely. In fact, we've been struggling mightily for the last few years with this uptick in behavioral lashing out of patients, whether it's verbal abuse or physical abuse. There's a workplace violence task force here that's enterprise-wide. Gosh, when we had, I don't know how many of you remember this, in 2010 we had a shooting incident here, and that resulted in a behavioral alert group, in addition to some other groups that were looking at what we call like type 2, under OSHA, type 2 violence. That's patients on staff, for instance, or anybody on the company. So we definitely look at things like expectations of patients. We've created posters recently in certain emergency departments to say these are acceptable behaviors, these are not acceptable behaviors. It's in the patient handbook. It used to be buried on page 26. I think it's a little bit further up the queue about patients and families' expectations when they come into the hospital. And I think you raise a really good point about, and I'm going to be very sensitive to this because I know there's a lot of sensitivity about it. And I completely believe in patient family-centered care. Don't anybody take me wrong. But the pendulum swung really hard towards patient family-centered care, where hospitals tend to be a little bit more mall-like. I mean, when you walk on the mezzanine level, it kind of looks like the Towson Mall a little bit. You know, where you have concierge service, you've got these grades that we're worried about, for instance, and those expectations too, which are important. I'm not saying they're not important. But I think what we're starting to see now is exactly what you're talking about, and that's this concept that maybe the pendulum swung a little too hard this way. And there's a right place for it, meaning hospitals aren't hotels. You know, we do believe in customer service and patient family rights and centered care. But there is a quid pro quo. I mean, there is when you come into a hospital, you're coming here for health care, to be healed or to be taken care of. But we have this understanding that there must be a contract between us about what that means. So I think we're on the way to right sizing where the pendulum is. I'm not sure we're there yet, but we're getting there.
I was just going to say, we've had some success with safety agreement plans where the team and the patient both come up with expectations and possible consequences. And so we've really tried to hold those patients accountable to their actions. I think that's come a long way. But I do think, to tag on to empathy, I think I've learned and become better at empathy with boundaries, and I will clearly state to someone that I am here to help you get better. That is my goal. What is your goal? And at the end of that is, okay, but we're going to do this in a safe way for both you and our staff here.
To tag on to that, I think that when we were talking about red flags, the only one that, and this isn't so much for AMA, but just for difficulties, is the longer a patient is here, the greater the risk of there being conflict. And part of that is about consistency or lack thereof. And I know that one of the things I've experienced in pediatrics, but I'm sure that this is universal, is that every provider has their own way of interacting with a patient, communicating with a patient, setting boundaries with a patient, and that if the expectation is you must use, I don't know, respectful language, what my expectation is for that may be different. My tolerance for, and I know my tolerance for profanity, sire. So, you know, but that's an example where someone else will say, they need to understand that they cannot speak that way here. Like, well, but it's the same way they communicate on any other day. It's, you know, anyway. But if it changes from shift to shift, then it becomes quite confusing for the person on the other side, who then expresses their confusion sometimes through increased frustration and, using the profanity example, profanity, which then is this, you know, spiraling effect. But that's certainly something that I've seen in terms of conflict with patients and families over time, then resulting in things like discussing leaving.
I have a clarifying question as a non-clinician about discharging. I imagine that here we see like a lot of very complex medical cases where patients do take the care team's recommendations and have a full course of treatment, and patients that are discharged into kind of tenuous situations. So kind of procedurally, what is the difference in discharging a patient AMA versus not?
When you discharge someone AMA, it's so when you discharge them, we do unfortunately discharge patients. I'm actually on service today, and we'll discharge a couple patients into circumstances that I think are suboptimal. Not because I'm trying, but because we're in East Baltimore. But the difference is, I feel like the things that can be done to make that patient as healthy as possible in the hospital have concluded, versus the patient, like in this case, where this patient would be viewed as having increased risk for going home, because many of the things that are felt to be essential to help that patient continue to improve literally cannot be provided at home, either because we need to set things up or because it's just not available in their home. And so in those cases, we often fear that the patient is taking increased risk by leaving before what we view as optimal treatment completed?
It's a really good question, and we're going to focus on that in an upcoming ethics for lunch because it's a big problem, yes. In the back?
I have a quick question. I am in an outpatient specialty, but when I was an intern several years ago, I felt like a lot of these cases would come up in the middle of the night. At like 2 in the morning is when it would most frequently I'd get the page that the patient wanted to leave AMA. And I just had a question, I guess, for legal or risk management. Because there are no attendings around to do a capacity assessment. So what are the recommendations in those cases?
I hate those calls. And I get those actually pretty regularly.
Yeah.
The last time I was on call, I got one of those. Clearly you don't want somebody leaving at 2 o'clock in the morning, period. And so if somebody's going to start bolting for the front door, we're not going to tackle them, right? But we would do everything we can to get them transport to go from point A to point B. If there is no point B, because that's what often comes up, especially with homeless folks or people, the worst case scenario is somebody homeless that can't walk in inclement weather, like a foot of snow outside and they want to walk out the front door. Really, you pull everything you can together to convince that patient to just stay until the morning, until you can arrange for a safer discharge for that person. Most of the time, I'd say 99.9% of the time, it works, and they end up staying until we can give them clothing in the cab, or get them to a shelter, or wherever they need to go, or home, or a friend's house, whatever it is to get them safely out. If they're incapacitated and they want to leave, that's kind of slightly different, because now you're talking about really a huge uptick in vulnerability for that patient. We would try to contact any family or friend that could be an authorized decision maker for that person to help continue to keep them in the hospital until we could suss through whatever their outpatient needs would be, or keeping them in the hospital another day or two to get them better optimized for a safer discharge. It's never easy. It's always difficult. And in fact, we had one situation recently that was really bad, where a family was taking somebody out of the hospital, and we were literally trying to keep them in the hospital, but at some point you say, okay, we'll get you a cab, and then cross your fingers and hope that things go well for that patient. And in this case, it ended up doing okay, and ended up coming back in.
And I guess just like if every AMA should have documentation that they have the ability to make that decision, and technically how staff can't be documenting that, right?
Yeah, that's a fabulous question.
Ongoing discussion for the Department of Medicine right now, because all good things happen at 4 a.m.
We used to be able, several years ago, we could.
Yeah, so the plan, and there is no law about this, by the way, so we're kind of flying by our bootstraps, as it were. Is that if there's a resident that's on during the night and they've got a sticky situation like that, the plan is for the resident to contact the attending and have a discussion with the attending about what's going on, get guidance from the attending, document it in the record, and then the attending will come in the morning and then do the capacity assessment. But the goal would be to hold on to that patient until the attending can assess them as humanly possible. But the resident, residents cannot do a capacity assessment. LPNs, RNs, CRNPs can't do a capacity assessment. It's got to be the attending physician and a second licensed physician, unless the patient has no means of communicating, like intubated and sedated. Then it only has to be the attending. But the bottom line is, residents at night, you're kind of stuck by calling the attending and letting them know what's going on and trying to come up with the most effective care plan in that short period of time until they can get somebody into assessment.
So this clearly is a really complex issue, and there really are no easy answers, although I think our panel has given us some guidance in terms of, first of all, assessing, does this person have capacity? And as Jeff said, there's a formal capacity assessment, but Mark and others last month, our Ethics for Lunch was on assessment of capacity. It is a clinical determination, and everyone on the team has a role to play in bringing forward, does this person understand what do they understand? That really does require everyone to participate so that we've got the fullest picture of who this person is, what it is that might be driving their decision making or their request, documenting that. And then the second part of that is, do they actually understand the consequences of the decision, of the request? And are there opportunities for us to understand that better? Are there any places where we might intervene? And certainly we want to document that as well. And I think another piece of this in terms of our community is more dialogue around the circumstances that might lead a person to make that request. Are there things about the individual patients? Are there factors that are present in the team or in our system that may create the conditions where those requests come up more often? And are there any things that we could modify in that process as well? And then the last piece is really how much effort is necessary in these circumstances. And I think a lot of times that's what clinicians struggle with. And that is a place where I think it is helpful to engage our resources so that we can together, really assess, have we gone through these steps? Do we have all the facts? Do we have the information? Are there modifiable parts of this case? And who else might help us in trying to figure out, is there a way forward or not? And then how do we take that perspective and be able to step back and say we've exerted sufficient effort, we have followed our process, this is an unfortunate outcome. And to be able to say, okay, this person is making a choice we wouldn't recommend, it's not one we would choose for ourselves, and yet people make unfortunate choices. And that, I think, is another whole piece of work for us to support each other through that process and to be able to recognize when our empathy has kind of gone awry and we're feeling more responsible for the outcome than perhaps maybe is our responsibility. Does anybody else have any last comments?
I think there are a lot of AMA myths that should be just taken off the table. So there's actually a really fascinating study, I'm jealous that I didn't do it, that looked at how many times when a patient leaves AMA, the insurance refused to pay. So how many of you have heard people threaten, tell people, patients, if you leave AMA, the insurance won't pay, right? Like super common. It's not true, actually, and by and large, they actually looked at patients that left AMA, and by and large, not uniformly, because the insurance, if you aren't clear, never always pays for anything. By and large, the companies do not reject all claims if you leave AMA. So that is a myth that we can put aside, and when we think about threats, that is something that we should really rethink using to try to convince the patient to stay. And I really don't find that to be often that helpful. If you find yourself in that place, you probably need to everyone take a deep breath because you're probably not in a good place. There are also a lot of myths about what can be done for people that leave AMA, and you sort of hinted on that, Simone. And so, like, when a patient leaves AMA, it is true that we have to be thoughtful about how we aid them in making decisions that we think are poor, but that doesn't mean that we tell them we won't do anything. And so it still is incumbent upon us as healthcare workers to ensure that we facilitate the safest plan possible for the patient, even if they're leaving against our medical advice or medical recommendation. And so if they need IV antibiotics, we should really think about what is the best oral antibiotics that we can give them, wound care supplies. And so it is incumbent upon us as healthcare providers to really try to risk mitigate that discharge, even if we can't take away all the risk. It doesn't make us say that we agree with the patient's decision, and so we don't really assume legal responsibility, and you can correct me if I'm wrong, by trying to make the discharge safer, but that really is what we should be doing. I think people get really nervous that I think are worried that it will make it seem like we agree with the patient, but that's actually not the case. And so I think those are important myths that I've heard or seen. And that, things like finishing the discharge paperwork, you can't always do it because sometimes patients are sort of really motivated to leave and they leave before you can finish. But if you can finish their discharge paperwork, those things to just risk mitigate, try to facilitate an appointment if possible. I think those are important things to think about when patients express a desire to leave before we're ready for them to do so.
Anybody else? Last. Jeff, you have anything else to say?
Don't hesitate to call risk management. Just throwing it out there, actually Megan, who's sitting in the audience a couple of months ago, she's looking at me like, please don't mention my name. We actually did a tally of how many calls we get monthly in legal, and it's about 1,000 a month.
Wow.
Right. Now, they're not all legal questions. A lot of it's pastoral counseling, it's just supporting the team. But we firmly believe in contacting the legal department. But what I would ask is if something doesn't pass the sniff test with a family on admission, like if you really want, like let's make us part of the team earlier and not when it escalates and gets blown out of proportion and everybody wants a guardian, which won't happen for 2 weeks at least, by the way. You can't get guardianships at the drop of a hat, so just call us, but call us earlier with a problem than like later in the game.
So just to tag on to that, our ethics committee and risk management work pretty closely together a lot of times, and so just reinforce the call early. Don't wait until things are so sort of depleted that there's not much to work with. The earlier that we can all bring those resources, the better outcome we're likely to have. So let's thank our panel.